We are gathered here today in the shadow of loss, not to mourn a person, but to honor an institution whose silent labor safeguarded millions of lives. The Centers for Disease Control and Prevention was never meant to stand in the light. It was our sentinel, working in quiet rooms and distant laboratories, watching the invisible currents of disease so that we might live unaware of the dangers drifting around us. Its work was measured in absences, the outbreaks that did not happen, the hospital wards that never filled, the funerals that never came. For decades, this agency carried the weight of vigilance on behalf of us all, transforming science into systems, uncertainty into action, and risk into resilience. But now, we find ourselves here because that shield has been broken. In a few short months, leadership has been stripped away, programs dismantled, expertise scattered. The quiet engine that powered prevention has been slowed to silence, and with it, the defenses we once took for granted grow thin. Today we speak these words not only in reverence for what has been achieved, but in warning for what is being undone. This is a remembrance, yes, but also a reckoning. For as we recount the stories of lives saved, we must also face the reality that without the science, the structure, and the resolve the CDC embodied, those stories will no longer be written. In the silent workings of the nation's public health infrastructure, few systems demonstrated the quiet power of the CDC more than PulseNet, its nationwide genomics-based outbreak detection network. For decades, this program connected laboratories across states and territories, giving epidemiologists the ability to identify related strains of bacteria that might otherwise have looked unrelated. This capability, the CDC's activity, became the foundation for something transformative: the ability of food safety authorities to act quickly, issuing targeted recalls and notifying the public when danger was imminent. Without PulseNet's continuous sequencing, tracking and coordination, contamination events would have played out slowly and invisibly, harming far more people before detection. Those efforts shaped practice in profound ways. Food producers, distributors and retailers learned to respond not days later, but immediately, because CDC-linked data revealed outbreaks as they were beginning. Public health departments had the information to trace the source of contamination before illnesses cascaded. The ecosystem depended on trust. The laboratories that sequenced samples relied on the CDC's reference databases, the states relied on the CDC's modeling expertise, and the food industry adapted its safety procedures based on alerts derived from CDC's insights. Together, this network saved lives, not in the abstract but directly, by preventing tens of thousands of cases of foodborne illness annually and hundreds of hospitalizations. Epidemiologists sometimes call this interruption of transmission chains, where swift intervention breaks the causal links that otherwise propagate outbreaks. When the CDC's capacity is stripped, the chains of transmission will be allowed to run their course. Without a functioning PulseNet, clusters of Salmonella, Listeria, or E. coli infections become harder to spot early. Foodborne pathogens, often stealthy and dispersed, cross state lines undetected until they cause widespread harm. Industry compliance weakens because the authority to guide recalls fractures. A delay of days in detection means hundreds or thousands of additional people exposed. A delay of weeks is catastrophe. What took decades to build, a data-driven prevention network, underpinned by a scientific backbone only the CDC could sustain, can unravel quickly once investment, expertise, and independence are undermined. So we pause here to honor a simple truth. Lives saved are seldom counted, and illnesses avoided rarely make the evening news. But behind so many quiet dinners and safe kitchens, the CDC stood guard. If we silence its voice and dissolve its reach, we do not silence risk, we invite it back to the table. When silence guarded breath, and breath returned to grace, the unseen hands restored what peril would erase. The hospital is where we expect to be healed, yet historically, it was also where many became gravely ill. In the early 2000s, central line-associated bloodstream infections, CLABSIS, were killing thousands of patients every year in intensive care units. The CDC became the architect of change. Through the National Healthcare Safety Network and evidence-based guidelines, the CDC created a framework of best practices, what clinicians should do when inserting and maintaining central venous lines, and how hospitals should track compliance. These were not just recommendations, they were science distilled into action, born from decades of studying infection pathways, microbial ecology, and hospital workflows. The CDC's activity, coordinating surveillance, publishing protocols, and training professionals, built a foundation strong enough to transform daily care. Practice followed where guidance led. Hospitals began adopting standardized insertion checklists, mandating glove and barrier protocols, enforcing hand hygiene, and auditing themselves against shared metrics provided by the CDC. Data were not just collected, but returned to hospitals, enabling them to compare their infection rates against national benchmarks and take corrective action. In epidemiological theory, this represented a powerful feedback loop. When high-fidelity data are captured, interventions can be rapidly adapted, leading to even stronger reductions in transmission risk. Over time, the numbers revealed the scale of success. Bloodstream infections, once considered inevitable, plummeted by more than half, saving up to 27,000 lives over the span of a decade and sparing patients incalculable suffering. But here too, the future now teeters. Without the CDC's capacity to maintain the NHSN, update guidelines and provide technical support, hospitals will again be left to chart their courses independently. The harmonized network dissolves, checklists drift out of date, and the surveillance systems that once illuminated hidden failures will go dark. Infections will creep back silently, patient by patient, until the gains of 2 decades are erased. The epidemiological principle here is clear. Without continuous data and adaptive interventions, progress in infection control reverses quickly. What was won through vigilance can be lost through neglect, and so we lament. Every reduced infection was a family spared grief, a patient spared pain, a hospital spared tragedy. These were victories earned not with heroics, but with discipline, patience, and persistence. If we let this engine of prevention stall, the bloodstream will again become a battleground, and the healing place will once more become a source of harm. When seasons turned to threat, and threat was turned aside, the quiet work of watchers held the restless tide. Each year, a new wave of influenza threatens millions across the country. The virus itself is a master of reinvention, mutating rapidly through antigenic drift, and occasionally reconfiguring more dramatically through antigenic shift. Against this restless adversary, the CDC became the orchestrator of one of public health's most intricate annual undertakings, guiding the formulation, recommendation, and deployment of seasonal flu vaccines. The CDC's activity extended from surveillance systems spanning the globe to modeling predictive strain circulation patterns, from assembling expert panels to coordinating nationwide vaccine recommendations. This groundwork transformed chaos into preparedness, ensuring that millions of doses could be produced, distributed, and administered on time. The impact of this work unfolded in practice at every level of society. Pharmacies, hospitals, schools, and clinics followed CDC schedules, mobilizing resources to make vaccination widely available. This was the second link in the triad, the adoption of evidence-based guidance at scale. The epidemiological principle underpinning this is herd immunity. By increasing the proportion of individuals with immune protection, we not only shield the vaccinated, but also slow transmission chains, indirectly protecting those who cannot receive the vaccine. In the 2023-24 flu season, the CDC estimated that vaccination prevented approximately 9.8 million illnesses, 120,000 hospitalizations, and nearly 7,900 deaths. These numbers are not abstract statistics. They represent grandparents who survived another winter, children spared time in hospital beds, and communities that continued functioning while influenza threats were blunted. But influenza is relentless, and without the CDC's stewardship, it would gain the upper hand. If the infrastructure that monitors strains, coordinates vaccine formulations, and disseminates timely recommendations erodes, vaccination uptake will fall. Mismatches between circulating strains and vaccine design will become more common, protection will weaken, and health systems, already stretched, will face surges of preventable hospitalizations each winter. Influenza thrives where preparation falters. The epidemiological chain becomes inverted. Fewer vaccinated individuals mean higher reproduction numbers, faster epidemic growth, and waves of unnecessary loss. So we pause to honor a quiet triumph, millions walking through a season untouched, their safety unnoticed precisely because of success. Without the CDC, we are left vulnerable, our defenses fragmenting, and the next epidemic of preventable influenza suffering becomes inevitable. Let us not dismantle the shield before the storm. When shadows gathered close and grief became the sky, the silent one still mapped where countless lives would lie. If influenza is a recurring threat, the overdose epidemic has been a uniquely American catastrophe, one marked by shifting substances, fragmented data, and cascading tragedy. Here too, the CDC's quiet power lay not in direct intervention, but in illumination. Through systems like the National Vital Statistics System and collaborations with states, the CDC's activity was to track overdoses in near real time, identify geographic hotspots, and model emerging trends in substance use. By connecting mortality data to the substances driving them, whether prescription opioids, fentanyl, methamphetamine, or polysubstance combinations, the CDC provided decision-makers with a high-resolution map of a moving crisis. Without these insights, states and local responders would be fighting blind. From that foundation, practice began to shift. States used CDC data to target where naloxone distribution would save the most lives, where medication-assisted treatment needed scaling, and where community interventions could stem supply and harm. Law enforcement agencies, clinicians, and harm reduction advocates alike aligned their actions around the intelligence that CDC data generated. This represents the second element in the triad coordinated behavioral change driven by evidence. Epidemiologically, this reflects the principle of adaptive targeting. When the epicenter of risk moves, the response moves with it, compressing the time between trend detection and intervention. In 2024, these data-driven approaches corresponded with a 27% decrease in predicted overdose deaths compared to the prior year, roughly 81 lives saved every day. And yet, this fragile success now hangs in the balance. If CDC's overdose surveillance capacity wanes, we return to a world where response lags reality. Without rapid data on emerging substances, fentanyl analogs, or cross-state surges, naloxone shipments arrive too late, treatment programs are under-resourced where they are needed most, and outbreaks of overdoses can spiral unchecked. In epidemiological terms, the control loop breaks. We move from proactive suppression to reactive cleanup, and the slope of deaths steepens once again. The human cost of even a few months of blind delay is staggering. Here, lament deepens. Behind each daily data point was a name, a family, a life cut short. The CDC gave us not only insight but hope that this curve, unlike so many others, could bend downwards. To weaken that capacity is to choose drift over direction, to let darkness settle where light was painstakingly made. We mourn not only what has been achieved, but what stands now to be lost. When terror split the air and fear became the ground, the faithful raised their torch where chaos circled round. When the COVID-19 pandemic struck, the nation faced its starkest public health trial in a century. The virus spread with a speed that defied containment, and the early months were marked by uncertainty, fear, and loss. In this maelstrom, the CDC's work became a lifeline. The CDC's activity spanned nearly every dimension of pandemic response, monitoring viral spread, guiding mitigation policies, coordinating with vaccine developers, and preparing the nation for the largest immunization campaign in its history. Its scientists worked alongside partners worldwide to track mutations, model case surges, and rapidly translate evolving evidence into clear recommendations. Through the Advisory Committee on Immunization Practices, the CDC provided the framework for equitable distribution and priority setting when vaccines became available. In the fog of crisis, it served as both compass and anchor. The practice element of this triad was unprecedented. States, pharmacies, hospitals, and local health departments synchronized their efforts with CDC guidance, creating temporary clinics in stadiums, schools, and parking lots. Clinicians learned in real time how to manage mRNA storage requirements and communicate risks and benefits. Community organizations partnered with the CDC's outreach campaigns to counter misinformation and improve vaccine acceptance. From an epidemiological perspective, this was the largest mobilization of population-level immunity in US history. The results were staggering. By November 2022, CDC models estimated that vaccination averted approximately 3.2 million deaths and 18.5 million hospitalizations, preventing a catastrophe on a scale that few could truly comprehend. The cascade is simple yet profound. Vaccines lower individual susceptibility. Fewer infections lower the basic reproductive number, RRO. Reduced transmission shields the entire community. Each shot rippled outward as protection, quieting exponential growth into controlled decline. But this triumph carries a bitter warning. Without the CDC's independence and authority, future pandemics will unfold in the absence of a trusted coordinating center. Already, the narrowing of vaccine recommendations and the sidelining of ACIP's deliberative processes undercuts both coverage and public confidence. If data pipelines falter, if messaging fragments, if distribution is left uncoordinated, the public health firewall collapses. Epidemiologically, it means we shift from suppression to vulnerability. R0 climbs, preventable chains of transmission ignite, and hospital systems are overwhelmed. What was averted once can roar back if readiness is dismantled, and so we grieve not only for the lives lost but for the fragile victory endangered. The pandemic revealed what a prepared CDC could do. It also revealed how much suffering occurs when preparation fails. To undermine this capacity is to invite a future where speed, science, and coordination no longer meet crisis, and where grief, not prevention, becomes the defining rhythm of response. When illness stalked the womb and fever claimed the bed, the quiet covenant ensured the living, not the dead. Beyond emergencies, the CDC's most profound work unfolded in the quiet hum of everyday life, far from the spotlight. For 3 decades, the agency guided the Vaccines for Children program, ensured equitable access, and continuously refined childhood immunization schedules based on the best available science. This enduring CDC activity, supporting state programs, funding providers, monitoring safety, and tracking uptake, built the invisible architecture of a healthier nation. It is hard to imagine today, but in living memory, measles sickened hundreds of thousands annually, polio paralyzed children each summer, and pertussis took infants before their first birthdays. Through relentless stewardship, the CDC made such tragedies exceptional rather than routine. The second element in this triad is the transformation of practice, the normalization of immunization itself. Pediatricians, public clinics, and school systems built their workflows around CDC schedules, and families across socioeconomic divides accessed vaccines their parents once struggled to afford. Over 30 successive US birth cohorts, this coordinated system maintained high coverage rates for diseases once feared. In epidemiological theory, this represents herd protection at scale, an intentional lowering of effective reproduction numbers, RE, below the epidemic threshold, achieved through collective action. The results are extraordinary. Among those 30 cohorts born between 1994 and 2023, the CDC estimates that routine childhood immunization prevented more than 508 million illnesses, 32 million hospitalizations, and 1,129,000 premature deaths. Entire generations grew up never knowing wards filled with iron lungs, parents fearing infant fevers, or funeral processions for preventable infections. But here too, the future is fragile. As CDC authority wanes, so does the scaffolding that sustains this success. Recommendations become politicized, safety surveillance stalls, and confidence erodes. Missed vaccines compound over time, creating pockets of vulnerability where outbreaks incubate. Measles, once nearly eliminated, resurges in clusters. Polio, detected again in wastewater samples, threatens to reclaim the lives it once stole. The lesson of epidemiology is cruel but inescapable. The pathogens wait. The absence of vaccination is not neutrality, it is permission. Without the CDC's stabilizing presence, decades of progress can collapse in a few short seasons, and so we must speak plainly. The millions of spared hospitalizations and the million lives saved are not historical artifacts. They are fragile, renewable gifts. If we fail to maintain the trust, infrastructure, and science behind them, we trade protection for risk and silence the agency that once held the line for our children. To weaken the CDC is to gamble with futures we cannot afford to lose. When borders could not hold and sorrow crossed the sea, the joined hands bore their gifts where breath was meant to be. The CDC's reach extended far beyond United States borders. In laboratories, refugee camps, and rural clinics across the globe, its global immunization divisions served as the backbone of disease elimination efforts that reshaped human history. For decades, the CDC coordinated with the World Health Organization, Gavi, UNICEF, and local ministries of health to stop outbreaks before they spread, train epidemiologists, and build laboratory capacity where it had never existed before. The CDC's activity here was extraordinary, deploying rapid response stop teams to halt measles epidemics, tracking vaccine-derived poliovirus across continents, and sustaining the sophisticated networks required to ensure vaccines reached even the hardest-to-reach children. These were not one-off interventions. They were patient, coordinated, generational investments in global stability. From this foundation, practice shifted across entire nations. Governments built immunization programs modeled on CDC protocols, health systems relied on CDC-trained field epidemiologists, and international surveillance networks were harmonized under the agency's stewardship. This became the second link in the triad global actors adopting CDC-guided standards and strengthening their own infrastructures. In epidemiological theory, this represented convergent immunity, where interconnected populations raise collective protection thresholds, pushing pathogens toward eradication rather than containment. The impact was monumental. Routine childhood vaccination programs worldwide prevent an estimated 4 million deaths every year, with CDC estimates projecting that more than 50 million lives will be saved between 2021 and 2030. Within those totals, measles vaccination alone accounts for nearly 19 million lives spared, and hepatitis B immunization another 14 million. These are numbers of breathtaking scale, measured not in isolated victories but in civilizations altered, futures rewritten, and epidemics silenced. And yet today, that global bulwark is unraveling. With thousands of CDC positions eliminated, its international workforce diminished, and its expertise scattered by political interference, partnerships that once relied on America's steady hand now stand leaderless. The complex coordination required to respond to emerging threats like polio outbreaks, yellow fever surges, or cross-border measles epidemics will fracture without this center of gravity. Viruses and bacteria obey no borders. When our surveillance fails abroad, they arrive at our own doors undetected. We live now in a shrinking world where the absence of CDC capacity reverberates far beyond Atlanta. So we mourn a global promise slowly extinguished. The silent success of 50 million children growing into adulthood, untouched by once fatal diseases, was the gift of coordinated science and sustained resolve. If we dismantle this, we are not only abandoning the world, we are abandoning ourselves. Without vigilance, the pathogens wait, and they will not wait long. When silence holds the wire and guidance leaves the field, the absent hand withdraws, the steadfast shield unsealed. And now, we must face the reality of what has been done. In the span of months, the CDC has been stripped of its leadership, its independence, and its workforce. On July 31, 2025, Dr. Susan Monares was sworn in as director of the CDC. Less than a month later, she was gone, the shortest-serving director in the agency's history. What followed was an exodus of extraordinary public servants. Dr. Deborah Houry, Dr. Daniel Jernigan, Dr. Dimitra Daskalakis, Dr. Jennifer Layden, and countless others, their resignations citing political interference, collapsed budgets, and the erosion of scientific integrity. Veteran epidemiologists now describe the agency's condition bluntly. The CDC has been decapitated. This was not just a change in leadership, it was a dismantling of capacity. In February, 1,300 CDC employees were laid off, including every first-year officer in the Epidemic Intelligence Service, the very corps trained to deploy when outbreaks emerge. In March, 2,400 more jobs were cut, entire divisions eliminated, and core functions like chronic disease prevention, HIV programs, and maternal health support disassembled. Key surveillance systems were shut down, entire laboratories shuttered, programs tracking epidemics here and abroad went dark. What took generations to build, a latticework of data, trust, and expertise that kept millions alive, is being undone in a season. The implications are stark. The ability to detect outbreaks early, to mobilize rapid responses, to translate science into coordinated action. It is not abstract capacity, it is the thin membrane between stability and crisis. Without it, foodborne illness spreads further before it is found. Hospital infections creep back into ICUs that had tamed them. Influenza surges fill emergency rooms. Opioid overdoses spike as supply chains shift unnoticed. COVID-19 and its descendants gain room to evolve unchecked. Childhood vaccination falters, and pathogens we thought buried stir awake. Beyond our borders, Measles, yellow fever, and polio flow where we no longer look, and in time they return to us. This is not a hypothetical risk. It is an inversion of everything the CDC achieved. For decades, the triads we have recounted, prevention flowing into practice, practice saving lives, defined the rhythm of public health progress. Now those triads reverse surveillance becomes silence, guidance collapses into confusion, and suffering once spared will return in waves. This is the epidemiological certainty we inherit when institutions are hollowed out. And so we lament. We lament for the scientists who devoted their lives to protection and were dismissed. We lament for the children who will face illnesses their parents never knew. We lament for the millions abroad whose fragile victories now tremble without our partnership. Most of all, we lament the loss of something rare and irreplaceable, a national covenant with prevention. The CDC's triumphs were not miracles. They were the result of patient science, unbroken vigilance, and a belief that the public good mattered.